So, first case is going to be a patient with thoracolumbar deformity with severe osteoporosis. We'll talk about ways to address the osteoporosis preoperatively. So this is a 75-year-old female retired pharmacist. She presents with back pain, difficulty standing upright, limited ability to do ADLs, and she's having escalating amounts of narcotics for back pain, and now she's on pretty high-dose MS-Contin. She has a history of known osteoporosis. She's currently on calcium and vitamin D, and she's had multiple fractures that are atraumatic in nature: metatarsal fracture, acetabular fracture, pubic ramus, proximal humerus. She also has hypertension and hypothyroidism on levothyroxine. You can see that she's had surgeries for the majority of her fractures and some non-fracture related surgery as well, Achilles tendon repair. And she's also had a bilateral oophorectomy. So this is her preoperative DEXA scan of both her spine and hip. If we looked at the worst T-scores, you see the left femoral neck is negative 2.8, and you see the associated FRAX results and her risk of osteoporotic fracture. These are her radiographs. We won't belabor, that's not really the point of this session, but she has a pronounced thoracolumbar deformity with some instability and driving her disability. Her MRI demonstrated no significant neural compression. And we're looking at a CT scan using Hounsfield units. We see that the average here is 51. Anything really below 100 is no bueno. This is really bad. So plan. So I'll kick it to the group here. Maybe Roger, you want to start on, and I can go back to any of the previous slides.
Yeah, I'm happy to start. Yeah. Just so you're aware that we're seeing the cases for the first time, as are you. So we're trying to formulate a plan on the fly here. I would say that this patient has a very, very high risk for fracture. So independent of the surgical issues and the spine pathology and anticipatory interventions, her BMD levels with the DEXA, her history of fractures combined paint a picture of someone who's got a very, very high risk of fracture. And so if this patient's coming to me in clinic, I'm very concerned that she's going to have a fracture within the next year or two, an imminent risk of fracture. She meets criteria, as far as I'm concerned, for being aggressive, as aggressive as possible in the front end with respect to management. Now, as an endocrinologist and these patients that come in, they all get an evaluation just to make sure that they don't have a secondary osteoporosis concern diagnosis, because we do want to make sure everything that we can optimize is optimized in order to have the best response to therapy, in order to have the biggest fracture risk reduction. So there is a lab evaluation that was kind of standard for all patients that are going to come in which we're basically trying to check the boxes on various different conditions that could adversely affect bone health. And so this patient would get essentially our kind of a standard panel that we have that just reflexively on our referrals to the clinic, it states, have you done this, to try to expedite this process. And so we really want to get all those labs when they hit the door. And then we're essentially optimizing non-pharmacologic interventions while we're then presenting pharmacologic treatment options to the patient to decide, and working through what would be at times a laborious authorization process, as we are all familiar with. And then we try to optimize non-pharmacologic interventions for this patient. So that's optimizing calcium, optimizing vitamin D. There's really not necessarily a significant fracture risk reduction with those interventions, but it does paint or set this foundation for what we think will optimize the response to pharmacologic intervention. So it's important to just be mindful. Sometimes people think the calcium, vitamin D is somehow going to magically improve the bone mineral density significantly and reduce fracture risk significantly. It's really not that much of a reduction in fracture risk, but we do want to make sure that those are optimized in order to get the best response to therapy. That is my ideas.
Just a couple follow-up questions. And I think one, just from a really practical perspective, from a surgeon's perspective, if we were to see this patient in clinic and then refer to skeletal health, if you had like your perfect world as an endocrinologist, when would the surgery happen? After, to do everything as perfectly as you felt like you could?
Well, if the patient can afford to get, I would say, at least a year of therapy, I think you're going to see the really significant gains in bone strength and fracture risk reduction. So if that is possible, at least a year of therapy would be, in my mind, an optimal time to then consider an intervention. Now, keep in mind, in my mind, it's not necessarily clear whether there's going to be a significant change in surgical outcomes at this particular moment of where we stand with the publications. There's a lot of mixed results, and so I don't think it's necessarily definitive. You can certainly cherry pick different studies that would suggest that there's going to be a dramatic improvement, but then there's also a number of studies that may not show a difference. But if you want to have a situation in which the bones are significantly stronger and the fracture is significantly reduced, a year of therapy would be, in my mind, optimal, at least. Yeah.
And then what would be like the low end to where it wasn't like as if we had done nothing, but we at least made like a little bit of an improvement?
Again, that's a tough hypothetical. You don't see, if you look at from a fracture rate difference, you really don't see much of a separation in the first kind of 6 months. So if you imply from the response to osteoporosis medication, bone protective therapeutics, and looking at fracture risk reduction, you're going to start seeing that kind of separation in essentially in the first 6 months. And so the implication would be that there may not be a difference within the first 6 months. That said, certainly osteoanabolics are fairly immediately active, and so there may be some benefit within that window, but you really start seeing the separation about the 6 month mark.
Okay. Raj, if you saw this lady in your Seattle spine pathway, what would you think your evaluation of her would be? What would your group recommend?
I think a lot of the points that you've discussed, Elikos, are front and center. One is how are you going to optimize this patient to get to surgery? Surgery is really the only endpoint here with this type of deformity, and patient's pretty miserable with it. She's also quite educated. I think I read she's a retired pharmacist, so she knows what she's getting into. I like that Hounsfield unit picture that you showed where you circled. Was that UIV that you circled there? Was that lumbar spine?
Mid-lumbar, yeah.
So, part of it is getting her on the right pathway and having Bone Health living with you now for a year. That's a really great news. We did not have that in Seattle. We tried to employ. I wasn't even an endocrinologist. It was actually an APP that was working with an endocrinologist, but never happened. So we would actually refer to an endocrinologist and then wait. The problem that we saw in many of these was that the insurance wouldn't pay for the medication, even after they saw the endocrinologist. So we were looking at writing that up. I'm looking at Kellen, but we saw a high rate of rejection even after they went to the endocrinologist from the payers really. That being said, I think putting this patient on some type of a bone optimization pathway would be ideal. I didn't see any other were there any other red flags except for that?
Mainly it was the MS Contin, escalating narcotic doses.
Yeah. So, and did you calculate an MED level?
I did not. No.
So we've published a lot of work in that area too, about MED levels and what levels portend to patients not being happy. Some people have talked about getting that MED level down 50% and then operating. The data, science behind that's kind of soft, so you have to make that decision. we would refer patients above a certain MED criteria to the anesthesia pain service. They would manage the weaning protocol. They do all that. I don't know of any surgeons who would do that themselves, but if there are, is there anybody in the audience that would wean this patient from their narcotic themselves? No, right? You'd want some enhanced expertise for that. And so that's probably the next optimizable factor before going to surgery.
Definitely. To the MIS guys in the room, Martin, Aaron, what do you think about MIS reconstruction for this?
I think that, similar to what Coy was talking about yesterday, I see a, more or less de novo deformity. I think taking a harder look at CT scan to look at areas of potential autofusion would be important. But beyond that, I do think that the parts of this that are going to be challenging are not necessarily going to be not less challenging with open surgery. There's a lot of stuff that need to be navigated around in important fixation points. But I do think that she would be a candidate for a hybrid anterolateral and MIS approach posteriorly. Martin, what do you think?
Yeah, I think I would do the same. Provided her bone quality is optimized and all the other factors. For her, how I would see this, she's leaning onto her convexity. So, Peking University just came out with their new classification existed in braiding in 17, so she's at high risk for being malaligned. I think I would place inner bodies at 4551, and if I don't level that out, I would actually just do a release. So since I'm there, I would release those disc spaces from the side, like probably how we should do, but not place inner bodies, and then just do a mini open PCO at that area to realign.
Nice.
So, I think it utilizes all the skills. You get the benefits of an open exposure when you need it, and you leave the muscular envelope closed and moving on that. But I definitely think I'd still do a staging case for her, especially.
Does the degree of osteoporosis give you concern about the disc space, placing cages?
It does. I think for MIS, that's probably the greatest limitation, just because the risk of subsidence or flatness is much greater, because that's just what you have to leverage. I think because the inner bodies, you're lifting the bone. And for any patient who comes to see me, they always get a DEXA, I look at their Pounds fields. And when they're on the cusp, I tell them about that. And it is still going to be a tactile experience on how much you can lift or how much you just.
Yeah, Steve.
Distal fixation is a big problem in this case. To build anything without having this strong foundation to the art. What are you guys' strategies working around these implants that are already in there?
Yeah. So I think Steve is bringing up a really key point. Is this an old suicide attempt or a car accident or?
No, but he raises the question of whether that was the case because she has the acetabular fracture too.
Yeah.
But no, I think this is all insufficiency fractures, sacral fractures.
Really?
Yeah.
That acetabular reconstruction is from an insufficiency. I find that hard to believe.
Sorry, the sacral fracture.
The sacral fractures, yes.
But the acetabular fracture, that was from a car accident.
Car accident, yeah. I think Steve brings up a good point that when you have this amount of pelvic hardware and you're going to need a solid base of your construct, you're going to have to utilize some important strategies. I think this would be a navigation case for me. And I've used a number of them over the years, but for me, it would probably be either stealth or 7D or augmented reality. One of those three is what I would use for this. If you can't find a corridor, which I think is what you're alluding to potentially on the, I don't know what's left or right there, Lekos, but which side's the acetabular reconstruction? Is that left or right?
Right.
Right. On the right side, you might have to do only unilateral pelvic fixation. I've had to do those before, but obviously that pushes me more towards putting an ALIF at L5S1, either primarily or secondarily.
Mm-hmm. Okay. All right. Well, what we did was we sent her to a pain specialist to help wean down on the narcotics. I referred to endocrinology, and then we considered this operation in an open manner. So she saw an outside endocrinologist. Sorry, this is a little bit small font, but they summarized the DEXA scan, which you saw before. They, stated that there was no steroid use, no hormone replacement therapy in the past, and no stones. And then she had been on alendronate and then stopped in 2019 because of some dental work and had not restarted. And she was on calcium. The dosing and vitamin D is shown there. Her BMI is on the low side, 20. And actually deep, I realize it's not on the panel, but not sure where he is. Anyways, so on the lower weight side, and Dan, if you want to comment on either optimization of the underweight. I know you talked about losing weight, but if you have any comments on how to help people gain weight, we'd love your thoughts as well. Yeah.
There are weight promoting medications like mirtazapine, but when we are trying to promote weight gain, we want to make sure it's done also through healthful things, focusing on protein and minimally processed carbohydrates. Carbohydrates are an easy way to gain weight, but you don't want to then induce like diabetes or elevated A1C if you're not having a appropriate balance. But really getting a food log from a patient can help because most people just have their own sense of normal. So what I do is normal to me. What you do is normal to you. But for a patient who's underweight, they're so used to not eating much and their food cues and hunger signals are probably so low that you have to have guardrails. So at a bare minimum, have this number of protein shakes, but in an optimal setting, do X, Y, and Z.
Okay, great. And then this was the endocrinologist's plan, which is to restart Fosamax and continue with calcium and vitamin D. And then through some private discussions, communications, we asked them to start a bone building medication. So, Roger, what do you think about this?
This is not me as the endocrinologist.
No, this is not.
Yeah.
I'm
just
outside hospital, private practice endocrinologist.
Yeah. So the Fosamax therapy ended in 2019. So you've got it sounds like a 4 to 5 year, basically drug holiday. Yeah. And so you're now in a time window when there's expected to be a pretty significant washout from the medication. So you can almost kind of envision there's somewhat naive bone because we're always concerned about how well you're going to respond to an anabolic in the setting of a prior antiresorptive because you're going to blunt that response. And so the sooner that treatment is to that antiresorptive therapy when it's bisphosphonate, keep in mind this is not the denosumab, but the bisphosphonate, you will not see the response as if it's a de novo patient. So it's important to keep that in mind. But I think there's enough time here that you're likely to see a pretty robust response to an osteoanabolic with that past history of the Fosamax. It's a little bit challenging in this case because I was looking at the DEXA scans. They've changed different sites, so it's hard to know how this BMD has changed over time. You in order to make longitudinal comparisons, ideally the patients have the DEXA done at the exact same facility, the exact same machine, exact same tech, the exact same as much as you can reproduce in order to see these longitudinal changes and accurately report them with a test that has some built-in inaccuracies to it. But in situations where you have different scans, you can look at the T-scores to give you a sense, and so there is an implication that there has been a significant change in bone mineral density of the hip. You've gone from a T-score of the hip of -1.8 now to -2.5, and that's a pretty significant change. So it would suggest that there is some degree of active bone remodeling. There's some loss of bone mineral density, which in my mind sets the stage for a bone that's likely to be much more responsive to an osteoanabolic. And again, I'm a little biased in the setting that I'm sitting here towards leaning towards the osteoanabolics, but it is a patient that I think would respond really well. And I think that it's entirely reasonable. It really comes down to how you value that fracture history in gauging that fracture risk. And I think that there's more of this evolution of about thinking about that and really putting them into a category of this high risk category, and then you leveraging that basically fracture risk towards pushing for therapy. It's still, we get a lot of pushback. Even though I'm an endocrinologist, we get denials, and it's an iterative process to try to work through it. But a lot of times we can justify with that history of fractures, and I think it's reasonable. I don't know if the question was about combining the two. Is that, or would you say adding it or switching?
I think it was a switch.
Switch, yeah, okay. Because and so I think she's a candidate that I think would respond really well based upon the information provided.
Okay. So soon after she started Timlos, she started having abdominal pain and diarrhea. She thought this was food poisoning. And then she stopped it and then tried it again and had diarrhea again. And then also noted decreased urination. Is that a common side effect?
Some of it is. Some of them, I would say you can see this. You can see some nonspecific abdominal discomfort. Usually there's palpitations or orthostasis, dizziness, and the symptoms last a few hours after the injection, and then they seem to resolve. The nice thing about Timlos is it comes in a delivery device in which you dial the dose up to the full dose, and as opposed to Forteo, which is basically get a full dose or not. And you basically pull the plunger out and you give the dose for Forteo, but Timlos you can dial it. And many times in situations like this, we have the patients pull back on the dose and actually try to titrate up just to build a little bit of a tolerance. And very, very often it's very successful. And so you can actually, just because of that first response is pretty dramatic, you just basically counsel through that and work towards just working your way up. And a lot of times that's successful. So I don't feel that this symptoms and these events necessarily preclude the continued use of Timlos.
Okay.
And there is a difference between the two products. So sometimes there may be a different response to Forteo. So I would consider if for whatever reason, even with the dose titration, smallest dose still having issues, I think it's worthwhile to try Forteo to see whether there is a similar response and whether this is basically drug specific or within the class. And so I think that would be a reasonable next step.
Okay. Yep, and that's what happened. So they switched her to Forteo, and without any further side effects. And she took this for 3 months, and then we did surgery. These are her reconstructive post-operative films, and we were able to navigate actually dual iliac fixation on both sides. Amazingly, there were quarters in between those big screws, and we cement augmented the top. She had some proximal junctional kyphosis, but no frank failure. And she's about 2 years post-operatively. She has very little back pain. She's weaned off all of her preoperative MS Contin, and now only on ibuprofen and Tylenol is needed. She likes her posture. She gained 2 inches of height. I'm not sure how much weight she gained or lost, but I don't think it was significant. And as I said, the PJK was asymptomatic. So she's walking a mile per day, and she completed Forteo for a year. So I think the outcome so far has been relatively good. I wanted to ask you about the stopping of the Forteo. Is that a good idea?
I was going to say, is there another line that says that she switched over to something else? My concern is that in this situation, if the Forteo, if you stop within a year, you will lose any of the gains within a year. And
would you go back to a Fosamax?
Yeah, I would go back. I would go to some degree, you can also, if you, unfortunately, she's losing sites to really monitor her bone mineral density, which makes it a little bit challenging longitudinally following her. If there was a significant decrement that you're really trying to make up, you could argue for continuing therapy for a full 2 years and even adding additional osteoanabolics. But regardless of whether there's sequential osteoanabolics after that treatment's done, she needs a antiresorptive. And I would say, given the past use of alendronate that tolerated well, I think that's an appropriate option, or giving just a single infusion of reclass and just covering it for a year. But definitely needs an antiresorptive. Otherwise, you're gonna lose the gains.
All right, that's something for. Go ahead.
So I was going to say, interesting, with her gain in 2 inches, you probably dropped her BMI below 20. The plan you had mentioned of 3-to-1 data, but I see a 4-to-1. Happy with horizontal
Yeah, good eye. We will definitely follow up on the Fosamax. Rosa, we need to make sure she's on. Yeah. So we did a 3-to-1. We only put structural cages at 4-to-1. This is going to Dr. Gupta's point of releasing a level. So in this case, I get concerned about fixing that obliquity with a cage at 3-4. She's a little bit least laterally at that level. So I'd like in these types of situations to put structural cages 4-to-1, horizontalize 4 to the sacrum, put just morcellized graft in and BMP at 3-4. It loosens it up, and so it's easier to bring it around. So that's a common technique that I use for these types of deformities.
I mean, that's actually what I was referring to earlier in lateral.
Mm-hmm.
If 4 is not horizontalized, but since the patient's lateral, I would essentially do that same thing and just release probably up to 1-2 because I can, and then just leave graft there.
Yeah.
Just so whenever it shifts back posteriorly, it'll also have a chance to do it.
Yeah. It's a nice technique. We didn't talk a lot about coronal plane deformities, but if we were to touch upon this lady's balanced. So the bowel classification would be A, but if you look at Obaid, her trunk is starting to shift to the right, to the convexity. So this is the type of patient, if you straighten out that mid-lumbar curve with too many releases, make it a little bit more flexible than it already is, and the lumbosacral fractional curve is not corrected appropriately, she's go decompensate to the right. So a lot of the work for this needs to be at the lumbosacral fractional curve. Okay, well, thank you. Let's go on to our next case. And if we can bring up the slides. Rahul, you want to come up?
Morning, everyone. We have a complex topic, but probably relatively quick presentation because this case is still yet unresolved. But in context of what we talked about, we have a case of a patient who's then 75 when we saw them in clinic. They had a history of a T8 to S1 fusion that was done at an outside hospital. And the presenting complaint actually when they came to our clinic was that they'd had multiple months at this point of hardware protruding through multiple cutaneous defects, along with significant worsening back pain and inability to maintain upright posture. Patient's medical history, at least in terms of things that are listed, is not super remarkable, except for the fact that they have a low BMI, which we'll talk about. The surgical history is as you see up here. The patient underwent in 2021 a T12 to S1 fusion, which I think was complicated by early failure and fracture at the UIV of the fusion site of the fusion construct at T12. So they were taken back just a few months later for an extension and revision of that construct to T8. It sounds like they actually did quite well for a little bit of time immediately after this. They had good relief of their preoperative back pain, but sometime in early 2024, I should say, they had worsening of the back pain and they started to notice the protrusion of the hardware through the cutaneous defect. They were initially seen in our clinic in November 2024. At that time, in addition to the pictures, which I'll show on the next slide, the patient weighed 85 pounds, which was down from a previous high of 130 at some point over the previous year or two, which corresponded to a BMI of 14. Apologize for the quality, but this is a picture that the patient themselves submitted through the patient portal to us of what their back looks like currently. And I'd say the picture tells you a lot, but there's actually rather a lot more going on if you look at these upright scoliosis x-rays. I don't have the images that were obtained kind of at the various intermediate steps before she had her previous surgeries to comment on kind of like to what extent this has progressed or what it looked like before we all started. But if you kind of look closely at the CT here anyway, you can see sort of the kyphotic apex is located at about T11, which is also approximately where you can see that there's a cutaneous defect, or at least where the screw heads are starting to protrude through the skin. Same is true here as well. So I think at this point, we did a couple of things, but it might not be a bad time to pause and see what members of the audience or the panel think about what we should do reconstructively or preemptively for this patient.
I've seen this case a couple of times in my career, unfortunately. BMI 14, profoundly malaligned, miserable. So I think there are three things that you have to think about. One is obviously this BMI of 14, and in a patient who's in chronic pain and not eating, how are you going to get that up, right? And so I mentioned earlier about putting in a peg tube and having that monitored and done for some time. I've done this 3 times where once the nutrition is optimized and we are ready to talk about a plan, soft tissue coverage is going to be the most important thing, second step here. And so in the original operation that you do, once you get this nutrition situation fixed, is a debridement, because there is an infection. Spine is open to the outside world, so there will be an infection here. Debridement, and then a flap closure with a very good plastic surgeon who can then go back into the same flap. And so I work with the same guy for 20 years who's really good at this. And so he was able to open up a flap that he put in, and then doing your reconstruction at a 3rd stage. That's how I would tackle this.
So you covered first, let it heal.
Covered first, clean it out, let it heal. So that's, however, it might be lifelong antibiotics here, right? But at least a period of IV antibiotics followed by transition to some lifelong oral plan. Coverage, get it cleaned, get your CRP and everything normalized, and then come back and do the reconstruction. At that time, you're giving her a year of optimization. I think that's the best scenario for that. I mean, I have an N of 3 or 4 of something like this. But that's going to give you, I think, the best long-term plan. Now, if that's not possible, you could do your I&D, your reconstruction, and your coverage all at the same time. That's hard, though, in a patient who's very frail and who may not tolerate all of that.
Raj, what do you think? I mean, to me, one of the big considerations here is antibiotics lifelong or not. And so if you're going into it kind of like no matter what, she's on lifelong antibiotics, then to me that kind of pushes me more towards let's just get this all fixed all at once, because she's going to be on lifelong antibiotics anyways. Do you see that side of things, or not as much?
I think, Aaron, I think that's a very reasonable thing to do, right? And it really depends on your plastics team and how they want to approach this. I think it's very reasonable to do it that way. I think the challenge is going to be, BMI of 14. We were talking about 17 and 18 before and rolling our eyes at that. BMI of 14. That's a tough position. And how are you going to, get this poor lady to at least an 18 or 19 or 20? That may take a year or longer. Now, again, if you just put a feeding tube in this woman, send her home, a nasogastric feeding tube, I mean, that's not going to work. Right. I mean, because you're talking about months and months and months. So I think the more staging you can do here, the more you can kind of monitor her and get her to a point where, if this patient came and saw me, I would, and I've had patients come from Alaska and crazy places with these problems where I say, look, we're starting a 2-year journey here. Right. And so some of that is also, do they have, no pun intended, skin in the game here? Because this is a really challenging thing to deal with. Manish, what are your thoughts? I'd love to hear your thoughts, and Steve also.
I think the best thing to do for her to get the impacts out and decrease the infection burden. So remove everything, clean it all out, and then get some sort of soft tissue cover. And peg tube is absolutely, I agree with you completely. And once you get the healing of the soft tissue infection burden under control, then go reconstruct. What's going to kill her is sepsis, if you don't do anything, it's going to just get worse, and they get worse. So the first thing is to get the infection burden off, remove instrumentation, get nutrition and closure of the wound. The back pain is not going to kill her. So that's number one. And then number two, once the CRP set rate, like you said, are normalized, the nutrition is better, they've gained weight, then you can reconstruct it at a second stage. But that's like further down the line. I would not reconstruct at this time, because what's going to happen is the same bacteria are going to find these metal and the biofilm, and they're going to have a party. So once it's infected, it's always infected in my book. You know, there's some literature now, when you look at the histology and electron microscopy, the bacteria are in those lacunae. And once the immune system goes down or whatever, they come out again. So I think once you're infected, you're always infected.
Manish, before you comment, Steve, I'm also interested to know, I have one patient like this about 10 years ago where I actually discussed end-of-life care with her. So if she's 75 and she's had 8 spine surgeries and she comes to you like this, and she's unwilling to do, I agree with Manish 100% on the plan, and it's a long plan, it's an 18-month to 2-year plan. If she's unwilling to do that and she's at the end of her road, I think supporting end-of-life care is very, very important. It's a humane thing to do for somebody like this, and I think you have to discuss that also.
I would say as a general internist, the fact that she lost that much weight in a year is a sign that end-of-life care is a really good thing to bring up early on. Like that person has basically given up on everything if they've lost that amount of weight that quickly.
Do Manish or Raj, do you guys have any concerns about stability of the spine with, an extended period of time without hardware? I had one patient where I did that and they came in and their spine like completely fall apart.
That's there's 2 options in that scenario. The first option is clean it up and let it be and put them in a brace. The second option is, what I have done is I've taken everything out and put very minimal titanium implants just to kind of give some stability, like top to bottom, not screw in every hole, and that has helped me. But there are people that will come back with recurrent deformity, so there's no, those old days of Harrington fusions are gone. When they had Harrington fusions, they were really robust fusions. Now these fusions are stress shielded and they're wispy, they're not as good. So they will fall apart, but you have to watch out for that. But ideally, it would be no metal, and then once everything is healed, you put metal. But there are cases where you have to go in and put temporarily some titanium. Don't put anything else but titanium. It's a little bit more resistant to bacteria, biofilm. So I would do that temporarily to tie her over. And it's not as prominent, because if you go way up top and way on the bottom, the kyphotic part is like not prominent. So then you can come back with a third reconstruction.
Steve, let's ask Steve.
Yeah, I agree with Manish. The only, I take everything out and just like he did. And then coverage is the biggest problem here, which needs to be addressed. By the time you finish debriding and things, you're not going to have coverage on this. And so I definitely, this one would have a VAC treatment with me and a plastic surgery assessment. And then when I can get it mobilized or closed up, then it may take a few surgeries to get to that stage. And then consider a Jewett brace after for a little bit until we can get things under control, because if you're not going to have coverage, you're not going to be able to go back again either. So.
With that amount of soft tissue loss, do you think even with long-term nutritional supplementation and a good plastic surgeon, is that going to be enough? Or is there a situation where even then you've got to do something more?
I think that this one is tough, and I agree with you. At a BMI of 14 and in this situation, I still think, and I really want to echo what Steve and Manish said, even if you can get this wound cleaned, right, and get coverage, And let's say this patient is, I didn't ask you the ambulation status of this patient. How much is she doing at this point?
I don't actually remember, but I think she was capable of it.
So, I mean, again, if this is a wheelchair-bound patient already, and you could just get her cleaned out and get her covered and get her on a nutrition plan, you've still won. Even if you didn't do a big reconstruction afterwards. I just think you have to prepare this person for the length of treatment way up front. They may have waited to see you for 6 months, and they came from a rural location somewhere, and they think I'm going to go see Dr. Clark. He's a miracle worker. I've been waiting for 6 months to see him, and he's going to fix me. I think expectation management here is really huge. And then, if you hit a stop point in your treatment, you take the implants out, you debride it thoroughly, you get her flapped, and then, she's either not following up properly, or you got to send her back to the medical deserts. I mean, this is a complex thing. I don't know if they have medical deserts in Canada, Steve, but we have medical deserts in the United States. I mean, you go 30 miles east of Seattle, Washington, you're in a medical desert, right? So I don't know where you're sending her back to. Right? This patient probably doesn't live in San Francisco. So you got to think about all that stuff.
One thing I wanted to bring up is the social network. So the social backup for this patient is already big time failed. So I would never see this patient alone. I would require them to bring family members or friends, because it's the only way you're going to get her out of this. If she's already shown that she's failed miserably in her social situation, personal situation, she needs a lot of help. So that's very important. That's going to determine your success or failure.
You can't make up for love with titanium. All you young surgeons, listen to that. You cannot make what Dr. Gupta just said. You cannot make up for love with titanium. So if you don't assess this stuff when they come to see you, you can do the most beautiful reconstruction and show the greatest X-rays at 1 week, but will that actually heal and work in the long term? The answer is probably no.
Question for Roger. Any contraindications to starting any bone or medication with the second infection?
I'm not aware of any contraindication in that with respect to that situation. That said, I have no expectation that she would respond with this nutritional state. I mean, yeah, an anabolic therapy requires an adequate nutritional foundation to build upon. You're laying down new tissue, and so I think it would be likely on people's minds to try to help the situation, but unfortunately, I think it's just going to be a wasted effort until a lot of these aspects are dealt with. But in and of itself, the infection shouldn't be an issue. But that said, in the setting of an infection, you're likely blunting that response because efforts are being directed elsewhere.
If you were, when you reconstruct her, how do you reconstruct her levels? Do you feature the pelvis? Do you do any shortening operation to help?
I would do a shortening osteotomy at the apex of the kyphosis. Yeah, I would have to look at what the fusion looks like at the top there. If she's got a robust fusion mass at the mass at the top, I am not going above that. I'm stopping in that robust fusion mass and shortening the spine through the apex there. That's it. Manish, agree? Steve?
So I think one thing it's not very clear for this, but there's a telltale sign that her right leg is short. And that's contributing to a lot of the coronal deformity. So you have to take that into account when you do the reconstruction. So, but I agree with Rajiv, less is more. Get her lined up and get her get her like stabilized. Because otherwise she's, if they stop walking, they stop eating, they start dying.
So as I alluded to at the beginning, this is still a yet unresolved non-surgical case, but we did a couple of things. The patient was seen by a plastic surgeon with whom we collaborate rather frequently at UCSF, and we talked about a couple of options for soft tissue coverage, including a free flap, which didn't seem reasonable for a variety of reasons, including the fact that the patient would have to offload for a long time after surgery, versus local advancements. They also were able to see nutrition outpatient, so to everybody's comments about a G-tube and various options for enteral nutrition, they were actually able to implement essentially like a high protein, high calorie plan just by mouth. And to some of the points that were raised earlier today, it should be noted that this very obviously nutritionally deficient patient who would be pan positive in any screen actually has an albumin above 4 and a prealbumin above 20 at baseline. But nevertheless, I didn't write down the exact number, but have gained at least like 15 or 20 pounds over the course of 1 year of nutritional supplementation. So yeah. Here we go, 20 pounds to BMI of almost 18. And sorry, didn't mean to go through all of that, but this is our proposed plan with, as commented, partial VCR at T11.
So, question for you. So the wound is still open.
Correct.
So this was never debrided and preliminarily flapped. It's still open to.
We were planning on having her gain weight first before trying
Yeah.
soft tissue construction. Because the plastic surgery was concerned with the current state.
Yeah, you may want to let us do some debridement and wound coverage first, and then do this, and maybe you can get her from a BMI of 18 to 22, right? I mean, you've shown that's just with oral, right? You've already shown some success. She's not septic or sick from this, from this open wound. So you have time. Consider that. But I think your plan is otherwise going well.
I don't know, actually.
Yeah, we're going to skip the last case.
Okay.
Sorry.